Instagram post has been done, so I will also post. Okay, fine. Start. Fine. Hello everyone, myself Dr. Shaurya. So today we are going to start with a small, short, concise, crisp demo lecture for anatomy. Very basics we will be discussing. We will not be going into details, but yes, we will be starting with the first part, and after that, subsequent lectures we will be taking there in the app. But today, yes, the starting part. So let us start with the lecture now. And guys, so first we are starting with the very basics. So what you feel here is when you start with the structures. So what do you mean by anatomy? Anatomy generally means to cut and to then to see, right? Now, so when you are visualizing anatomy, you just look after cutting into any structure. For example, you cut into the upper limb or the lower limb section of a cadaveric anatomy, and then you see, then you analyze the compartments, right? For that, you will have to look at the different layers, superficial to deep, what you will encounter when you are monitoring the different layers, right? Now look at, guys, here when you are, suppose you have taken the section of the upper limb of a cadaver and you are cutting it and analyzing. So what are the basics you are going to get? The first thing that you are going to get is the roof. Okay, fine. And roof which will be made by skin. Then deeper to it will come the superficial fascia, right? That will contain the fat, cutaneous nerves and the vessels. Then deeper to it will come the deeper fascia, and the floor generally for any compartment, it will be made by the, you have the muscles and then the bone, the bony structures, right? Now one more thing I'd like to add here. When you see here, for example, this is the structure. Here the deep fascia will undergo some modification and will form the intermuscular septa. You can see here, as shown in this image, I'll show you. Deep fascia undergoes modification to form the intermuscular septa, like this, the way I have drawn here, and also in this diagram you can see here. Now every compartment, now it will have its own neurovascular bundle, guys. Okay, so here you see in the neurovascular bundle, generally you have the vein, you have the artery, and then you have the, guys. Now just have a look generally. So one important question point I'd like to cover here, that in most of the places wherever you find the neurovascular bundle, it is generally in the sequence of vein, artery and nerve. At some places, that means at very to be very specific for MCQ point of view, two places where there this sequence will not be followed. The two places are the first intercostal space and another one is the popliteal fossa. So just have a look. Where these are the places where the sequence of vein, artery and nerve and the neurovascular bundle will not be followed. Now have a look. After looking at this transverse diagram, now I will tell you how to identify what if they give you a cadaveric image and characteristic features of identifying a vein, artery and a nerve. So generally what will happen in case of veins, they are thin walled and they are collapsible in nature, whereas artery, they are thick walled and whenever you press them it recoils. They have a characteristic of recoiling, right? And arteries are thick walled, whereas nerve, you know, they are solid structures, nervous bundles, right? Solid structures containing the nerve fibers. They do not have any lumen, so when you will press them you will feel the structure is solid, right? This is the vein, the artery and the nerve whenever you analyze the transverse diagram. Now one key important point that I am going to tell you is, whenever in some places the neurovascular bundle, that is the vein, the artery and the nerve, when taken together, sometimes they are covered by sheath, a sheath of connective tissue, right? And this sheath of connective tissue is actually the modification of the deep fascia itself, right? And what is the clinical significance and what places you get the neurovascular bundle, guys? Question, yeah, neurovascular sheath related question. I'll tell you in anatomy, the carotid sheath, very frequently asked question, right? The femoral sheath, there also you see the neurovascular bundle covered by a sheath of connective tissue, right? Generally these sheaths are modifications of deep fascia. Okay guys, now have a look. So what did we see here? Two important question points. Again, from the sheath, here will be asking you about carotid sheath. This we will be studying subsequently further. Then we have the femoral sheath. Okay guys, ये हम लोग आगे when we will be studying about the head and neck, we will be studying about carotid sheath. When we will be studying about the lower limb, we will be dealing with the femoral sheath. Coming back to another point, one very important law is Hilton's law. What do you find in Hilton's law? See, Hilton law generally states that any nerve that is supplying the muscle in a particular compartment will always supply the same skin, the bone and the structures present in that particular compartment. कहने का मतलब, I told you when you had an upper limb, you dissected it, right? And when you dissected it, you found compartments. I told you every compartment. Suppose in this compartment, or look at this printed image very comfortably, you can see here you have the skin, superficial fascia, deep fascia. The modification of the deep fascia is forming the intermuscular septa. I will highlight it here. You can see. So now it is acting at a one separate compartment. Now in one particular compartment, you can see here you have a separate nerve, an artery and a vessel, vein, right? So these separate structures present. So these nerve, vessel and artery are present for a one particular compartment. So nerve in one particular compartment that is supplying the muscle of this particular compartment will also supply the overlying structures, that is the skin and other structures of this particular compartment. Simplified language में I will tell you guys. For example, suppose you take an arm. Just take example of the arm, right? Now you have the arm here of a person. Just have a look guys at my body. Arm is further divided into anterior compartment and the posterior compartment, right? In the anterior compartment, you have the muscles, biceps brachii, right? And coracobrachialis, right? Like this. So just have a look here. In the anterior compartment, there is a nerve called musculocutaneous nerve. So the musculocutaneous nerve will supply, if it is running in the anterior compartment of the arm, it will supply generally all the muscles present in the anterior compartment of the arm. Good guys? Understood? Chalo. Come back guys. Suppose in the posterior compartment you have the nerve called as the radial nerve. So if radial nerve is supplying the triceps, it will supply the muscles present in the posterior compartment. People are telling for audio. Just a minute. Please check for the audio. Just a minute guys. Somebody, people are telling for audio. Excuse me, bhaiya. Is audio okay? Please guys, somebody comment. Is the audio okay guys? Please somebody comment. Is the audio okay? Just please check for the audio. People are telling for audio. Ayan, Atari, no, so no problem. Okay, fine, fine, fine. Then we will continue. Now, come here. So I told you, so whenever you don't need to remember nerve supply for individual muscles, you just have to see the directly nerve running in the compartment, and you can remember very easily if a nerve is running in one compartment, particular compartment, it will generally supply the muscles of that particular compartment only. Fine. Now, and the other overlying skin and other structures of that compartment. Very simple. This is the clinical and practical application of Hilton's law. There are a few exceptions to it. We will discuss, but no need to worry. Gradually we will be coming around and I will be explaining with you the exceptions as well. So exceptions are few, but general and everywhere common things we will do it, so that we are having very easy way of remembering the nerve supply of different muscles, so that individually you don't have to waste your time in remembering nerve supply of every muscle. Come back guys. Now when you are studying anatomy, then what you are going to do, we have seen the compartment, we have seen the Hilton's law, very basic. Now what we are going to do, we have to look at the planes, different planes, because since you are studying the body and the anatomy, you need to revise and look at the different planes, right? You have to cut the body into different planes and then analyze. So now we will be studying about different planes. First plane is coronal plane, right? How do you remember the coronal plane? The coronal plane is like this. suppose, just have a look here, any plane that is separating the chest and the back, C and back. Just for example, very simple trick and very easy trick I'm going to give you. Any plane separating the chest and the back, pencil is not working. Any plane that is separating the chest and the back is the coronal plane. Any plane that is separating, right, the body into two equal halves will be considered as mid sagittal plane. Have a look here, guys. Pencil is not working. So this you have here is the coronal plane. How? Any plane separating the chest and the back, right? Any plane dividing the body into two equal halves, left and right equal halves, will be called as mid sagittal plane. Now, any other plane dividing the body in two halves, not equal halves, try to listen to me very carefully. Any other plane dividing the body in two halves, right and left halves, but not equal ones, will be called as sagittal plane simply. But if the plane is running through midline and to two equal halves, it will be called as mid sagittal plane. Now come, then you have the transverse plane and the oblique plane. Transverse plane is simply this one, that is running transversely through the body, transversely. And then you have the oblique plane. Oblique plane is something that is running like this, obliquely through the body. Now guys, we are going to look at the standard basic positions of the body, because if we have to study anatomy, then you have, while reading anatomy, you will come across multiple terms such as proximal, distal, right? Then other terms, what are the terms that you will come across? Medial, lateral. And do you know how do you decide these terms? Medial kya hai, lateral kya hai, what is proximal, what is distal? How will you decide? For this, first of all, you must know the standard anatomical position or natural anatomical position, right? So what is the natural anatomical position of the body? Whenever a person is standing like this, completely erect, right, and the eyes must be looking forward, hands should be at the sides with the palms facing forward, and legs are placed together with toes pointing forward. This is the standard anatomical or natural anatomical position. Look at me, standing erect, eyes facing forward, palms facing forward, right, and hands at the side, toes our legs are put together and toes also pointing forward, right? This is the natural anatomical position. Now there are some other body positions also that we will study in different medical contexts. What is supine? Supine is simply lying on the back. Okay? If you forget what is the simple trick to remember the supine position, it is just for very simple mnemonic I will give you, not mnemonic but a very simple trick. Lying on the spine is supine. Lying on the spine, spine is in the back, lying on the back is supine position. What is prone? Prone, lying on the abdomen. In Hindi you call pate as the abdomen, so lying on the pate, P for pate, P for prone, is prone position. Yeah, right? Now lithotomy. Lithotomy, I will show you the position. You can see here in the diagram, this is the supine position, this is the prone position, lying on the abdomen. Then you have the lithotomy position. Lithotomy position, it is generally used in gynecological and obstetric surgeries, right? And you find here, see, you can see that this is the position is called as the lithotomy position. And you can see here, patient is lying on the back and both the feet are supported by a footrest, right? And in this case, the perineum area is exposed, and this helps you in the obstetric and gynecological surgeries, right? So the lithotomy position is more commonly used by the people associated with obs and gynae department. Now, lateral decubitus position. This is nothing but the body lying on the side of the body. This is generally used for ear surgeries and other examinations as well. Just have a look. Right lateral decubitus and left lateral position, recumbent or decubitus position. Fine, guys. Just have a look. Now we will be moving towards, we have discussed the planes, the mid sagittal I have already told you. You have a look, mid sagittal plane running, dividing the body into two equal halves. The coronal plane separating the chest and the back. Very simple. You can see here I have found different color. I will indicate. the coronal plane separating the chest and the back, right? T, T, done. The transverse plane running transversely through the body, cutting the body like this, from a different color, transverse plane. And oblique, you all know, diagonally or something like this, running obliquely. Different planes we have discussed. Now we will be coming close to some terminologies. What are the terminologies? What is proximal, what is distal? So the basic terminologies for studying anatomy, right? What is medial and what is lateral and all. See, so first of all, proximal. What is proximal? Anything P for proximal, remember like this, P for proximal and P for pass, जो नजदीक है, right? Like this, have a look. Proximal, P for proximal, P for pass. Suppose if I am telling you the arm is more proximal to my body trunk as compared to forearm. Forearm is distal, right? Distal, D for distal, D for dur. From a very simple mnemonic or trick you can understand, you do not need to remember. Distal is dur, proximal is near. Okay guys, have we discussed? Now we will be coming to some of the basic movements. Proximal, distal done. What is medial and lateral? Tell me guys. Medial is anything closer to the midline, towards or near to the midline, right? Lateral is something that is away from the midline, right? So have a look guys. If this is the midline, anything close to the midline will be medial. Anything away from the midline or laterally away, that will be lateral. Okay, medial, lateral we have discussed. Proximal, distal we have discussed, right? Now we will have discussed the basic terminologies. So now we will be discussing the some of the basic movements as well, right? Now certain movements due to which there will be change in the angle. First of all is flexion. What is flexion? Flexion, suppose at a joint the two bony surfaces angle is reducing and the two articulating surfaces or the parts are coming closest to each other, that is flexion. You can see in elbow the flexion, the arm and the forearm, the angle is reducing and they are coming close to each other. This is flexion. What is extension? Extension, you will see the angle between these articulating surfaces is going to increase maximally. Am I correct or not? See, maximum distance away, maximum angle increase. This is extension, right? What is adduction? Adduction, A for ADD. Adduction has add. Just have a look guys, adduction has add in it. Adduction, right? In adduction you will see anything coming closer to the midline. See here, adduction, I am adducting my forearm, right? Adduction, adducting the thumb, bringing it close to the midline. Adduction, anything bringing close to the midline is adduction. What is abduction? Just like subtraction, taking anything away from the midline will be abduction, right guys? Now what is internal rotation? Something just internally rotating any organ. Kahan use hoga? Where you will use it? In the orthopedics you might have studied about the FADIR, FADIR and FABIR, right? Flexion, adduction, internal rotation, या फिर right? Flexion, abduction and external rotation. So external rotation and internal rotation is generally used in these terms. क्या? जैसे देखो, for example, here in the leg now is internally rotated. I hope you can see me. The leg now, just a minute, let me create some distance so that you can look at me. The leg now is internally rotated here. The leg now is externally rotated. This is external rotation. Have a look. This is external rotation. This one is internal rotation. Internal rotated. Right? I hope now you understand. Now, special movement, circumduction and so what is circumduction? Nothing, very simple. I will tell you the term. There's a term called, you know, the circumference. What is circumference? It is a diameter around a circle. Suppose if I am moving my hand like this, drawing a complete circle, right? So this is circumduction. In the similar manner, if I move my legs like this is also called as circumduction. I hope we have discussed supination, pronation. We have told in terms of arm, forearm. Supination, what is supine? This is supination, and this one is pronation. Supination, pronation, supination, and pronation. Done, guys. The terms will we have discussed. I think. Just have a look here at the image. This one is supination, one is pronation. Have a look. Another, in terms of foot. For foot mein, there is some special term you use. You do not use extension and flexion. There is the reason I will tell you. So, what are the terms that you are using in case of foot? The terms are dorsiflexion and plantar flexion. In dorsiflexion, what is happening? The dorsum of the foot is coming close, angle is reducing, coming close to the shaft of the tibia or the shin of the leg, right? In plantar flexion or the plantar flexion, what is happening? The plantar part of the foot is coming close here to the back of the leg, right? This is plantar flexion and this one is dorsiflexion of the foot. Okay, guys. Now, some special movement. Again, what we have is the locking and unlocking movements, right? Generally, locking. What is locking movement? Suppose in case of knee, the joint movement is limited, right? The leg can flex in some direction, right? But it can extend up to a maximum limit only. Similarly, in elbow, you can see, right? Now, in the knee joint, there is locking and unlocking movement. Whenever there is locking happening, what will happen? Tell me. It will be performed by a group muscle called as quadriceps femoris muscle. Locking performed by quadriceps femoris muscle. Right? What is locking? Locking is this movement when you are extending your knee. Simply, just like the kicking force, kicking motion. Kicking motion. This is why it is also not only called as locking, but also described as kicking. Right? And apart from that, or footballer's muscle, that is why it is called as quadriceps muscles, can also quadriceps femoris can also be called as locking muscle because it is locking the knee to the maximum extent. It is also called as kicking muscle and footballer's muscle. Okay, guys. Now just have a look with me. What are the unlocking muscle? The unlocking muscle and unlocking movement, they are generally performed by the popliteus muscle. Right? We have very famous mnemonic here, that is UPLQ. Unlocking is done by the popliteus and locking is done by the quadriceps femoris, footballer muscle and the kicking muscle. Right? Now, some special movements, inversion of the foot and eversion of the foot. Right? Inversion, the muscles involved are, for the case of foot, they are the tibialis anterior and tibialis posterior. How to remember? Very easy. I will give you the trick. I and T look the same. For inversion of the foot, the muscles involved will be tibialis anterior and posterior. Now, everter of the foot, eversion, peroneus longus and peroneus brevis. The two muscles responsible for eversion of the foot will be peroneus longus and peroneus brevis. Now, just have a look, guys. Before coming to moving anywhere, we will be discussing about some of the bones and the bony features, okay, in the pectoral region and in the upper limb portion. Right? Now, we will be looking at the osteology part. So, in the osteology part, what we have is the bone is the clavicle. You can see here clavicle. Then what we have a bone? Scapula. Right? We have a bone called as humerus. In the pectoral region, 3 bones, major bones we have. Now we will be studying about all these bones and related MCQ points and important points regarding every bone. Chalo, coming here. Clavicle is also called as the collarbone and the beauty bone, right? Now, looking at the parts of the clavicle are generally medial part is medial 2/3 and lateral 1/3. Most of the books they tell this, right? But in the latest edition of the Gray's Anatomy, now they are mentioning medial 3/5 and lateral 2/5. Done. Now, guys, what are the unique points? The only long bone about clavicle, it is the only long bone that lies horizontally. Just have a look. The long bone to lie horizontally is the clavicle, right? The long bone with two primary ossification centers is also clavicle, right? Now, clavicle is also pierced by intermediate supraclavicular nerve. The long bone that is pierced by a nerve that is called as intermediate supraclavicular nerve. The bone is clavicle. Okay, fine. Now, coming to scapula. Suppose in exam they give you, and now just a minute, wait for a minute. If they tell you, give in the exam a shape of the clavicle, a diagram of clavicle, and they ask you to identify whether it is a medial end or the lateral end, how will you identify? Just have a look. The lateral end of the clavicle is generally flattened and broadened, right? Whereas the medial end, you can look, is more sort of rounded. Okay, now this will help you in identifying the medial end and the lateral end. Again, have a look. Medial end is sort of rounded and lateral end is more sort of flattened and broadened, band like. Done, guys. This is how we will be doing it. Now, coming to another bone, that is the scapula. It is a triangle shaped bone. Now you can have a look. It has two processes. There they can acromion process and the coracoid process. In scapula, they will ask you two questions. Very first thing, they can ask you to identify whether it is the ventral aspect of the scapula or the dorsal aspect of the scapula. How do you know? Very simple technique. In the scapula, there on the dorsal aspect of scapula, there is a process called as spinous process, right? So you can see here, this is a process called as the spinous process present on the dorsal aspect or the posterior aspect या पीछे वाले part पर scapula के on the back side. You can see this is the spinous process present on the back side of the scapula. Now this spinous process gives rise, here comes and flattens and forms a process called as acromion process. Okay, guys. Now we have the acromion process. Also at the very same time, on the ventral aspect, what is happening? On the ventral aspect or anterior aspect of the scapula, you will see the flat structures, some ridges are present like this, and no spinous process, but a process C-shaped structure or a C-shaped process called as coracoid process. Coracoid process is present on the anterior aspect of the scapula. From the anterior, what you are visualizing here, or this is this, you can visualize a little bit part of the acromion process. Okay, you can visualize, but acromion process is a part of spinous process present on the dorsal aspect of the scapula. I hope, guys, I am very much clear to you. If guys, I am clear, just give me a thumbs up. Now what we are going to look at, see, different regions in the scapula there are. So above the spine, the region will be called as, simple, above spine, supraspinatus. Below the spine, the region will be called as infraspinatus, right? Now with scapula, one question, very important question, they have asked you many times, winging of scapula related question, right? Again, ahead when we will discussing in not detail, we will be discussing this, but now also we will discuss this MCQ point, very important point. Winging of the scapula. The scapula's winging is caused by weakness of the serratus anterior that is supplied by the long thoracic nerve. Done. Winging of scapula. So how will it look? We will show you. This is the image. This is the image. You can look here. This is how the winging of scapula looks. This happens due to weakness of the serratus anterior muscle and supplied by the long thoracic nerve. Chalo. Now coming here to a bony structure called as the humerus. Now humerus, you can see here, it has many parts. Now we will be looking at the parts of the humerus. This one is generally the neck, right? And this one is the ball region kind of part. How to identify the part? See, medial side and lateral side of humerus. Now see, this one is the ball kind of part. So this is the head of the humerus that should be articulating in the glenoid cavity of the scapula, right? So this should be the medial part, right? And this part should be lateral part. Now it has two important epicondyles as well. On the medial side is the medial epicondyle, and on the lateral side is the lateral epicondyle. Done. Now in the medial and the lateral epicondyle, you have again different parts. I mean to say, I just like to tell you about not about the parts but the related structures. They are very important. Kahan important hai, I will be telling you. In orthopedics and in anatomy, this is very important because questions are framed from this, right? And in orthopedics they are also important. How? They will ask you about the supracondylar fracture, they will ask you about the fracture line running through the lateral epicondyle, they will ask you about fracture line running through the median epicondyle. I hope now you guys can understand why is it important. Now we have seen the humerus. Now guys, what we are going to do before studying anything basic, now we will be doing some more important movement. One more important movement we will be discussing, that is the movement of the thumb. Very important, thumb movements, right? Special movements we have discussed all. Now we are discussing about the movements of the thumb. So tell me guys, what are the various movements a thumb can perform? It can perform opposition. What is opposition? It is simply the basic counting movement, opposition, right? Thumb can perform flexion, thumb can perform reposition, thumb can undergo adduction, it can undergo extension and abduction. Now I will be telling you about every movement of the thumb. Why? Because this is important. Especially you have to differentiate between the abduction of the thumb and extension of the thumb. This is very important question point. So please be focused, and very important concept as well. Have a look. Suppose this is your palm. First look at me guys, at the what I'm drawing, and then we will be discussing, right? And this is the thumb. So if it is in the 90-degree plane, it will be called as abduction. Done. Just look at me here like this. This is the way. If the thumb is present at 90 degree to the plane of the palm, it will be abduction, right? If thumb is together with the palm, it is the natural adducted position. Just have a look like this. But if the thumb is present at 90 degree to the plane of the palm, it is abduction. Now if the thumb is lying like this in the same plane of the palm, you can look here, in the same plane of the palm, it will be called as extension. Okay guys, can you now understand? Now if the thumb is flexed, this is the flexed position of the thumb, then you have the opposition. I told you the counting movement. Done. I will draw for you. You can see abduction 90 degree, thumb is at the 90 degree. How to remember? A for abduction, A for angle. Thumb is present at an angle of 90 degree of the palm, right? Now have a look again. You have the fingers, and the thumb is completely attached like this to the fingers, like this. It is adduction. When the thumb here is folded like this towards the palm, it will be flexion. Opposition, you know the counting movement, and reposition you already know. Extension we have discussed. Special movements of the thumb we have discussed. Now what we are going to do guys, I will be helping you to locate the muscles, right? First of all, because we have studied the bony part of this region, bones of the upper limb and the pectoral, so we will be starting now with the muscle part. See, this is a demo class, so we are briefing and going in a very brief way, just looking at every point and the pattern that we will be teaching and taking class. Okay guys, so now just have a look. I will now help you in identifying certain muscles. How to identify different muscles? Have a look here. Here at the back region, major important muscles, you can see a triangle shape, right? A triangle shape muscle present at the back region. This is appearing as a triangle, but in actual the shape is of trapezium. And what is trapezium? It is a quadrilateral four-sided structure, right, with all four sides not equal to each other, right? This is trapezium, but in actual it is a trapezoid shaped muscle, but when you visualize it in a 2D diagram, it appears more like a triangle. Have a look. So a big muscle from neck to the back appearing like a triangle, it should be trapezius. Done. In the cadaveric image I will show you guys, just have a look here. This is the image. You can see this big muscle like this. I will shade it. This is the trapezius. Now how to identify, sir, whether they are asking trapezius or something else? Simply just focus. Clean plain structure, just the skins have been removed and everything is clean plain muscle structure is present, right? No other dirty structure looking. That means only the skin and the fascia has been removed and the muscle has been exposed. So this muscle should be trapezius. Now when they are showing you smaller muscles and the dirty muscles like this, see, you can see many smaller muscles. Can you see these two smaller muscles and these smaller muscles? Separate smaller muscles. Now dirty looking muscles, dirty looking structures, that means the upper muscle, upper cover of the trapezius has been removed and these structures below the lying below the trapezius muscles are being exposed. So now what are these three muscles? One muscle connecting from the neck region to the back of the scapula, it should be levator scapulae. Another muscle lying from thin muscle lying from this portion to the back of the scapula, it is rhomboid minor. A big muscle, a bigger muscle, again rhombus is shape. What is rhombus? You know, a quadrilateral with four sides equal, but the angle is not equal to 90 degree. Okay, again have a look. This is rhomboid shape muscle. Again one more, a bigger rhomboid shape muscle, so it will be called as rhomboid major. Done. We had a look at the muscles of the back region. Have a look here, guys. Now again we have one more muscle lying. Suppose this is the blade of the scapula ending, right? If I told you scapula is a triangular bone, this is the blade of the scapula ending, and at the lower portion you have the muscles. This one, you can see this muscle in the dorsal aspect or the posterior aspect is present and is going ahead, right? This muscle is called as latissimus dorsi. Now some of the MCQ points related to this muscle, latissimus dorsi, very important muscle. It is a twisted muscle, right? It is a twisted muscle. Second, latissimus dorsi is a muscle that is called as primarily climber's muscle. Done. Second MCQ point, latissimus dorsi called as climber's muscle. Another thing, latissimus dorsi is supplied by a nerve. Which nerve? Can anybody tell me? Thoracodorsal nerve. And what are the root values to it? It is C6, C7 and C8. Okay? 3 MCQ points regarding the latissimus dorsi we have discussed. The thoracodorsal nerve I have written here. I will indicate it to you guys. No need to worry. Latissimus dorsi, I told you, thoracodorsal nerve, it is supplied. The nerve root is C6, C7 and C8. Now come here to these three muscles what we were talking about. The smaller muscles, iska to kar liya. Ab aa jao idhar. We have talked about levator scapulae, the rhomboid minor and the rhomboid major, right? All these three muscles in the back region, small muscles connecting from neck to midline towards the scapula. Kahan aa rahe the? They were coming to the back of the scapula. Okay, or to the dorsal aspect of the scapula. Hence they are, all these three nerves are supplied by a nerve named dorsal scapular nerve. Have a look, guys, very easily. Just have a look very easily. See, all these muscles present attaching on the dorsal aspect of the scapula. So the name of the nerve is dorsal scapular nerve. And what is the root value to it? Root value is C5. Now Can you see a correlation? Dorsal scapular nerve having the root value C5, and they are attaching to the dorsal aspect of the scapula, and just below the scapula here, when the scapula blade ends, triangle angle of the scapula ends, here starts a muscle called as latissimus dorsi, supplied by thoracodorsal nerve, and the root values are C6, C7 and C8. Am I correct, guys? Just have a look. I have written in the notes also. Latissimus dorsi, thoracodorsal nerve, C7, C6, C8. Now levator scapulae, dorsal scapular nerve root is C5. Rhomboid major and minor, again dorsal scapular nerve root C5. I told you. Now we will look here in the schematic diagram also. In the schematic diagram, very clear. See, upper muscle, clean muscle, trapezius is present. You remove the trapezius, then you will visualize smaller muscles. Smaller muscle connecting from neck to the dorsum of the scapula is levator scapulae. Now from midline here near the spine to the dorsum of the scapula, again rhomboid minor, again similarly big rhomboid muscle, rhomboid major, all three connecting to dorsal aspect of the scapula and are supplied by dorsal scapular nerve root value is C5. Done. Right. Trapezius supplied by 11th nerve. Right. Latissimus dorsi supplied by thoracodorsal nerve. Nerve value C5, C6, sorry, C6, C7 and C8. Done. Now, can you visualize? Now, we will be looking at the muscle present in the shoulder region, and the muscle is, अब इधर आ जाओ, बाहर superficially it is the deltoid, right? Now, this deltoid muscle is supplied by a nerve called as the axillary nerve, right? Now, this axillary nerve is also related to the surgical neck of the humerus. So, what will happen in this case? Can anybody tell me? Here in this case, the axillary nerve, right, is supplying the deltoid muscle, right? And if there is injury to the axillary nerve, what will happen? In the long term, there will be wasting or atrophy of the deltoid muscle. Apart from that, this where will we also presence of regimental badge palsy. You might have read in your college days, and in the question we will see they have asked very frequently regimental badge palsy. Why? Deltoid is present in this region, right? And in this area, due to the injury to the axillary nerve, deltoid muscle being supplied is compromised, and the sensory supply is also affected since they are all supplied by the axillary nerve. So what will happen here? There will be paresthesia or decrease in sensation in the regimental badge area. This is what it is called as regimental badge palsy. Now, very important thing, one more thing regarding the deltoid, the ridge where the deltoid inserts here in the humerus, just above this ridge. This is an important point for of clinical relevance. Why? Because at this point only you give the intramuscular injection, IM injection in the deltoid. You might have seen when you have gone for vaccination, they see the ridge where the deltoid or inserts in the humerus, and just above it they give the intramuscular injection. Why? Because there's the least chance of damage to the neurovascular structures when you are giving IM injection just above the insertion point of the deltoid. Just above, you can see here, you can point the belly and they give injection here. You might have noticed it when you have gone to the clinics for taking vaccination. Now, important point, one more we will be discussing is, that is the rotator cuff. See, for the rotator cuff, you need to look at certain structures. Yes. So what are the muscles that are taking part in the formation of the rotator cuff? Very important. Supraspinatus, infraspinatus, teres minor and subscapularis. ये तो हो गया. But now how and why? I will tell you. See, very important point that I am going to discuss from very basic. Listen to me very carefully. See, head of the humerus. I told you when I was showing you the bone that this is the head of the humerus. Right? You can see the ball part of the region. Right? It is a part of ball and socket joint. But here is one problem. What is the problem? I will show you. Head of the humerus is complete ball-like structure. So here we are not only looking at the anatomical aspect, but also we are covering the important aspect of the orthopedics as well. So be attentive. Question आजकल integrated form में आता है और mix आता है, right? And not it is not only about the question, but about your medical career. When you are as an intern, as a medical officer, or as a resident, you will see cases of shoulder dislocation, recurrent shoulder dislocation, and hence rotator cuff is important. You must know why how what is happening here. So please be attentive. Now have a look. On the head of the shoulder, you can see on the head of the humerus, you can see the ball like region. Now this is your scapula. I told you in the scapula, I'll show you one thing. Just have a look. This is the part called as the glenoid cavity. And in the glenoid cavity, the head of the humerus articulates forming the shoulder joint. But there is a catch. What is a catch? The glenoid cavity is an incomplete cavity or a partial cavity. It is not a complete cavity. And since it is not a complete socket, what will happen? There is high risk of the head of the shoulder or humerus dislocating, right? And hence the head of the humerus is also not very much stable here. In order to stabilize the head of the humerus, the body has made some specific and some different arrangements. And what are those arrangements? I will tell you. See, around the glenoid cavity will be present a glenoid labrum. Suppose this is the scapula and this is the glenoid cavity. Around the cavity there will be presence of glenoid labrum. Like this, labrum will be present, right? Connective tissue layer. This will try to hold the head of the humerus. Apart from that, a musculotendinous structure, right? Different muscles giving tendons, and these tendons combining and forming a cuff or a musculotendinous structure called as the rotator cuff is also present here near this site. And what does this musculotendinous structure or the rotator cuff do? It provides support to the head of the humerus present in the shoulder joint, right? And it stabilizes the shoulder joint. So this is the function of the rotator cuff. Now, what are the muscles participating in the rotator cuff? I told you, you have the supraspinatus, you have the infraspinatus, right? Then you have the teres minor and the subscapularis. Among all these four muscles, three muscles, listen to me very carefully, three muscles. When I was telling you the anatomy of the scapula bone, I told you there is a supraspinatus region above the spine, infraspinatus region below the spine, right? Similarly, you will see the three muscles, supraspinatus, infraspinatus and the teres minor. These three muscles are present on the posterior aspect of the scapula or on the dorsal aspect, यानी कि पीछे वाली side पर. On the back aspect, the three muscles supraspinatus, infraspinatus and teres minor are present, right? On the anterior aspect, what is going to happen? On the anterior aspect, only one muscle, that is the subscapularis, will be present. Have a look here. This one is the anterior part of the scapula. Here we will have a subscapularis muscle present on the anterior aspect of the scapula. Now, since on the anterior aspect there is only one muscle and on the posterior aspect you have three muscles, so this is one of the main common reasons. You can try to remember like this: main common reasons for anterior shoulder dislocation being more common. Why? आगे एक ही मसल है सबस्कैपुलरिस, पीछे तीन तीन मसल है सपोर्ट करने के लिए टू द रोटेटर कफ. Therefore, this is the main reason anterior shoulder dislocation can be more common. You can remember like this. ठीक है? Now, orthopedics का भी important point कब है? Anterior shoulder dislocation more common. Why? One muscle आगे. Very simple trick. You can remember by this trick. Now, come. What you are going to see here, one MCQ point they have asked you, if there is teres minor, there is also teres major, right? They have asked you whether teres major is a part of rotator cuff or not. So your answer should be no, it is not the part of rotator cuff. So rotator cuff has only four: supraspinatus, again repeating, infraspinatus, teres minor and the subscapularis. Done, guys. Chalo. Now, two important lesions of the orthopedics we will discuss here only related to the rotator cuff. What are the two important lesions? Orthopedics का important है, question बार बार आता है, and clinically also you will see. One is the Bankart lesion, another is the Hill-Sachs lesion, right? I told you in the labrum. Suppose, just have a look, guys. Suppose this is the head of the humerus and this is the glenoid cavity. What will happen if there is dislocation of the shoulder and dislocation of the humerus, head of the humerus from the glenoid cavity? What can happen? It will come out. Also, I told you around the glenoid cavity there was a presence of connective tissue layer called as the glenoid labrum, right? This glenoid labrum can tear with the dislocation of the shoulder, and due to the, I told you, look at here, this is the glenoid cavity, there's connective tissue layer, labrum present. If there is dislocation, it can tear along with it the glenoid labrum. Along with the glenoid labrum, there can also be chipping of a small portion or section of the bone of the glenoid cavity. This is called as Bankart lesion, right? When there is dislocation of the shoulder, along with it there is labrum tear, glenoid labrum tear, and small portion of the glenoid cavity or glenoid, small portion of the glenoid rib can tear along with it or chip off. This is called as Bankart lesion. Done. One more orthopedic important point and concept that we will going to discuss is the Hill-Sachs lesion. In case of orthopedics, you will study. I told you anterior shoulder dislocation is more common. Suppose this is the head of the humerus and this is the glenoid cavity. It's continuous and dislocation, repeated dislocations in some person may be suffering from recurrent shoulder dislocation due to unstable shoulder joint. So in those persons, what is going to happen is due to recurrent anterior shoulder dislocation, humerus dislocated, but the muscles attached are already there. These muscles will pull the humerus. Humerus came out from the socket, but due to the pull of the muscles, it will go and hit. It will go and hit again on the back of the posterior superior aspect of the humerus will again and again hit the scapula. Okay? And due to it, what will happen? There will be indentation on the posterior superior aspect of the head of the humerus. This is called as Hill-Sachs lesion. Again, have a look. Humerus got dislocated due to pull of the muscle, came back and constantly hit on the scapula. Humerus got dislocated due to pull of the muscles, got back and hit on the scapula. This hit is on the posterior superior aspect of head of the scapula or of the humerus, right? So this will lead to indentation. Indentation means gaddha, bar constant hitting say on the posterior superior aspect here you can see, and this is called as Hill-Sachs lesion. I think I'm clear, guys. Am I clear, guys? Chalo. The important aspects we have discussed. Now what we are going to discuss is come here to some important arm muscles. Muscles we have started, muscles we will be dealing, and after that we will be dealing about nerves, and then further subsequent sections we will be going to sub further forms and the regions. Now just have a look. I told you arm, we have the two compartments, the anterior compartment and the posterior compartment. In the anterior compartment, what muscle do we have? We have the biceps, you can see here, right? Then you have the biceps brachii, brachialis and the coracobrachialis. Done. Biceps brachii, the brachialis and the coracobrachialis. Now just have a look. In examination, what they can give you? They can give you to identify the long head of the biceps, because biceps has name biceps, it means two heads. Okay, biceps brachii has two heads, the long head and the short head. In the posterior compartment of the arm, you have the muscle called as triceps. Triceps means three heads, right? So what they can give you? They can give you a cadaveric image and they can ask you to identify long head and short head. Very simple trick, I will tell you, you will not forget. Okay, first try to identify the landmark. What is the landmark? You can see here in the biceps brachii, the long head is generally present on the lateral aspect, lateral side. In the biceps brachii, again I am repeating, the long head is generally present on the lateral aspect, whereas the short head is present in the medial aspect. Have a look in the image I will show you. Dekho, this one laterally present laterally. This is the biceps brachii muscle, and this one is the long head. Why? Present laterally. This one is the deltoid muscle. You can see the long head is lying laterally in the biceps brachii. The short head is lying medially. One more thing I would like to say. Suppose if you forgot in the examination what is the long head, what is the short head, how to remember? Very simple trick. ध्यान से देखो क्या हो रहा है. In the long head is actually in the two-dimensional image or the cadaveric image, it is the long head that is appearing short. Can you have a look? It is the long head that is appearing short, and in the two-dimensional cadaveric image you can see it is the short head that is appearing long in case of biceps brachii. Very simple trick to identify. Understood? Now again, if they give you a cadaveric image like this, this is the posterior aspect of the arm looking at the triceps. So if they ask you to identify the long head and the short head, again very important clinical aspect. First try to identify deltoid. See, this is deltoid coming from the upper aspect muscle, so this must be deltoid, right? Now among these two heads, what is the long head and where is the short head? Very simple. Now I told you the head appearing shorter in the two-dimensional cadaveric image should be long head, and the head appearing longer in the two-dimensional cadaveric image should be short head. ये हो गया तुम्हारा आइडेंटिफिकेशन टेक्निक, कैसे पहचानोगे, ट्रिक, राइट, फॉर द ट्राइसेप्स एंड द बाइसेप्स. नाउ डन. अब nerve supply, I already told you when I was dealing with the compartments, I told you the musculocutaneous nerve is running in the anterior compartment of the arm. So according to Hilton's law, the musculocutaneous nerve will supply all the muscles present in the anterior compartment of the arm. Am I correct, guys? Yes or no? Yes. So just have a look. The musculocutaneous nerve will be supplying all the muscles in the anterior compartment of the arm, biceps brachii, brachialis, and coracobrachialis. Right? Now, there is one a little bit exception. I will not tell you now. First, let me finish and then we will deal with it. Coming to the posterior compartment, I told you in the posterior compartment the radial nerve is running. If radial nerve is running in the posterior compartment, then it must supply the muscles located in the posterior compartment of the arm, right? So radial nerve will supply the triceps brachii, done. Long medial and short lateral heads, right? Now have a look here. I will show you one very important thing. I told you one thing. So should we continue, guys? '24, okay. Excuse me, should we continue? Just give me a minute, guys. Guys, am I audible? Am I audible, guys? I think there's a lag or something. Okay, I am audible, right? Fine, 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 fine. Chalo, let us start. I thought we have lost the audio. Chalo. So now coming here. So what is the clinical relevance? Now we have discussed about the nerve supply, anterior compartment of the arm and posterior compartment of the arm. One exception I was talking to you about is the radial nerve. See, radial nerve has a very specific and unique arrangement. I'll show you. Look at this image. Now look at me. And now look at me, right? हाँ वही पूछ रहा था, नहीं मुझे लगा आई वाज आस्किंग कि पॉज्ड है। ओके ओके फाइन फाइन, तो ये ब्रेक आ गया ना इसलिए। हाँ, now have a look guys. You have the humerus bone here, right? And I told you about radial nerve. Radial nerve was present in the posterior compartment of the arm. But see, at some point near the shaft of the humerus, this radial nerve from the back side comes to the anterior side, right? Or from the posterior side or posterior compartment of the arm, radial nerve comes to the anterior compartment. Have a look like this. It was present posteriorly, but near at the site of the humerus, it went around the shaft of the humerus and came forward here to the anterior compartment. So what is the impact of it? Now since the radial nerve came in the anterior compartment, now it will say just give me a little bit some supply, because now I have come in the anterior compartment, right? And since it has arrived in the anterior compartment, what will happen? It will give a little bit supply to the brachialis. Okay, fine. To the brachialis it will give little bit supply. Understood this exception? Fine. Otherwise they will not ask you very frequently. Up, what we are going to discuss, very important, listen to me very carefully. They may have told you when there is orthopedics important question point I'm going to discuss, be very attentive. In the shaft of the humerus fracture, there is risk of severing or injury to the radial nerve. Very good. Now one more thing I'll ask you. I told you radial nerve was coming from the posterior compartment to the anterior compartment, and if it is traversing from one compartment to the other compartment, that means it must pierce the intermuscular septa. Am I correct guys? Just give me a thumbs up, or yes or no, tell me. Just have a look here. I told you in the compartment, you can see here you have a neurovascular bundle in every compartment. Since the nerve is coming from posterior compartment to the anterior compartment, it needs to pierce the septa. Why I told you? There's very important point. Because in the case of shaft of humerus fracture, there can be direct injury to the radial nerve first, and second thing what can happen, there is risk of entrapment. Since the radial nerve is piercing the face intermuscular septa, and from posterior compartment to the anterior compartment it is traveling, so due in case of radial nerve humerus shaft of humerus fracture, there is risk of entrapment of the radial nerve. And again entrapment of the radial nerve, if in shaft of humerus fracture occurs, the symptoms will be similar to radial nerve injury, that is the wrist drop. Okay guys, clear? So they can ask you in two forms. Never make a wrong answer or a wrong choice. They can give you two options in two forms. Either they would write you that if there is shaft of humerus fracture, there can be direct injury to the radial nerve. Very good, correct. This will lead to wrist drop. Very good. Or they can present it to you like this: there is entrapment of the radial nerve in shaft of humerus fracture, and this will lead to radial nerve injury causing to wrist drop. Understood guys? Both these are correct. And why this is happening? Understood? Fine. Now just have a look here. Here radial group, shaft of humerus fracture again. Have a look here. I also told you axillary nerve is present here, like at the neck of the humerus, right? Axillary nerve. Here axillary nerve was supplying the muscle. Which muscle? Deltoid muscle and the overlying skin. And the injury to this axillary nerve would lead to regimental badge palsy, right? Injury to the radial nerve, this will lead to wrist drop. Some aspects I will tell you more ahead when we will be discussing in more detail about the radial nerve. I will tell you that the injury to the PIN branch or the posterior interosseous branch of the radial nerve leads to finger drop. These things we will be discussing. No need to worry ahead, and we will be integrating every subject, not only anatomy but also orthopedics. Most of the things we will cover here itself. Also surgical aspects, when we will dealing with the prostate, we will be dealing with the hepatorenal pouch and other pouch. We will dealing everything. Pouch of Douglas we will be dealing with the epiploic foramen. We will be dealing with the other things. We will be integrating the surgical aspects as well. Every aspect we will be integrating and dealing, because nowadays the questions, we are not only discussing anatomy, but nowadays questions are asked in integrated form. So here we will be revising other subjects as well, along with studying the complete anatomy. Chalo. Now you can see medial epicondyle fracture. Medial epicondyle. Now this one is a medial epicondyle fracture. So there is risk of direct injury to the radial nerve, right? Ulnar nerve, sorry. in the medial epicondyle fracture, there's risk of direct injury to the ulnar nerve. Why? Because the thin ulnar nerve is passing along the medial epicondyle here, right? Just behind the medial epicondyle, the ulnar nerve is passing. Now, I will tell you one more thing. Have you read somewhere about the funny bone? What is funny bone? You might have all have seen that sometimes when you hit the elbow, it gives like a jerky current like situation, right? This is, and that is why you call the elbow as a funny bone, this bone. But actually it is not a bone, it is a nerve, and the nerve is ulnar nerve that is running behind the medial epicondyle. Whenever you hit it, it feels like current is going, and you call it a funny bone kind of thing, right? Understood? This is the ulnar nerve. Okay guys, today we have dealt with the muscles of the forearm, right? Their nerve supply, their functions, and important MCQ points we have discussed. A lot of them we have discussed about the rotator cuff, we have discussed about the deltoid, right? And we have discussed about the orthopedic aspect as well. We have discussed how to identify the cadaveric image of the back muscles, the back muscles nerve supply, right? And their important functions. So now one MCQ point I'd like to discuss one more. Before concluding this demo class, I would like to add two important points. First is climber's muscle. The climber's muscle was latissimus dorsi, important muscle. Apart from that, second muscle is pectoralis major. Okay guys, the second one is a pectoralis major. That is also a climber's muscle, but your primary answer or your first choice will always be latissimus dorsi. Done. Now nerve supply we have done. Trapezius nerve supply we have discussed. We have discussed how to identify the trapezius. We have discussed how to identify the shoulder, back of the shoulder muscles, right? You can look here. Now we are concluding the class, and other classes we will be discussing the anatomy in further detail. Thank you guys, and further topics we will be discussing. We are conclude the class. Conclude. Khatam. Finish.